Hello everyone, this is Kerry Anderson. Hope you all doing well. In today's video, I'll be talking about gastric problem if you have diabetes. So if you like the video related to my health, my way, I would like to request you all, please do subscribe the channel, hit the bell icon and give thumbs up so that I will come up with more and more videos with lots and lots of information. So here we begin, let's go. Delayed gastric emptying or gastroparesis represent the far end of the spectrum of this motility disorder, collectively referred to as diabetic gastropathy or the diabetic stomach. The diabetic stomach is a manifestation of diabetic autonomic neuropathy. It is characterized by potentially debilitating gastrointestinal symptoms and can also interfere with glucoregulation by contributing to a vicious cycle of delayed emptying of food or oral medication. The result may be late glycemic peaks followed by hyperglycemia and further delays in gastric emptying, or by hypoglycemia secondary to retention of food in the stomach. The goal of treatment of diabetic gastropathy is not only to prevent morbidity by controlling gastrointestinal manifestation but also to enhance glucoregulation and thus better control the basic diabetic process. Herein, strategies are processed for controlling symptoms of improving glycemic control in patients with manifestation of the diabetic stomach. Delayed gastric emptying or gastroparesis is a well-known problem in patients with diabetes mellitus. It is at the far end of the spectrum of motility disorder, collectively referred to as diabetic gastropathy or the diabetic stomach. Although often believed to be more common in patients with type 1 diabetes, it is actually also quite common in patients with type 2 diabetes. In one study of diabetic patients receiving oral hypoglycemic therapy, 30% were found to have delayed emptying of solid. A substantial proportion of patients with either type 1 or type 2 diabetes mellitus have scintigraphic evidence of delayed gastric emptying of radio-labeled solid meals, which may or may not manifest in clinical symptoms. Conversely, many patients may have symptoms such as nausea, vomiting, early satiety, bloating, and abdominal discomfort or pain, and yet have normal gastric emptying. Diabetic gastropathy is thought to be a manifestation of autonomic neuropathy. The underlying cause of diabetic neuropathy, as well as other complications of diabetes, is hyperglycemia. While the entire gastrointestinal tract may be affected by autonomic neuropathy, we have a growing awareness of the role of the diabetic stomach in particular as the locus of a vicious cycle of delayed gastric emptying, poor glycemic regulation, and ascending hyperglycemia. The purpose of this brief review is to focus attention on the importance of early intervention in the development of diabetic gastropathy in order to prevent the debilitating symptoms associated with it and to improve quality of life. Now, pathways of diabetic autonomic neuropathy. The pathopsychology or physiology of the neuropathic complications of diabetes follows one of at least two pathways. The first is non-enzymatic glycosylation, which occurs when a persistently elevated blood glucose level results in the excessive glycosylation of proteins such as hemoglobin, other circulating molecules, and cellular structures. This leads to the development of advanced glycosylation and products, impairing the normal function of tissues including collagen and basement membranes of cells and capillaries. The second pathway is enhanced activity of the polyol pathway, in which glucose is converted to sorbitol via the enzyme aldose reductase. They result in a decrease in the tissue myonocytol with far-reaching effect throughout the nervous system as the integrity of cellular information, including the sodium-potassium at pace system, is disrupted, nerve conduction velocity is diminished, and the anatomy of nerve fiber is altered. Diabetic neuropathy can impair functions anywhere in the nervous system. In the gastrointestinal tract, it causes an effect as autovagotomy. In addition, hyperglycemia results in cellular anatomic disruption throughout the gastrointestinal tract, but especially in the stomach. Nerve cell may swell with the loss of myelinated fibers, and smooth muscle cell may become rounded and problematic. In the stomach, motility may be reduced in the antrum and proximal stomach. There may also be problems. Hyperglycemia also has secretory effects in the stomach, including decreased secretion of hydrochloric acid. The net result of these changes is a reduction in affecting emptying, starting first with indigestible solid, then progressing to digestible solid, and eventually to liquids. The myoelectric and neuroanatomic consequences of hyperglycemia may be accentuated by the abnormal secretion of various hormones, including glucagon, gastrin, the gastric inhibitory peptide in patients with diabetes. Now, clinical impact of diabetic gastropathy. Gastropathy may result in a variety of potentially disabling upper gastrointestinal symptoms, among them postprandial nausea, with or without vomiting, early satiety, anorexia, distension, and abdominal discomfort or pain. However, some diabetic patients with impaired gastric motility are asymptomatic. Also, some patients may experience these symptoms without an established delay in gastric emptying. This situation may be the earliest stage of the disease process of autonomic neuropathy. The first evidence of gastroparesis may be poor glucoregulation. Gastropathy can contribute to various formation and intestinal obstruction, ulcer development, acute gastric during ketoacidosis or after endoscopy. Okay, so then that's all about the gastropathy. If you have a diabetes, I'll definitely come in the next video with my another content. If you have any questions, type in the comment box. So I'll answer to those questions. So till then, God bless you. Bye bye, and take care.